find new, you find you. So like the big guy, go to a local family owned business, your $1.50 further. This is what you want.
So what we'll do is we're gonna do our question concept, okay? So what I'm gonna have you guys do is whoever's dressed up, I want you to come to the front, and pull up your outfit really quick, and then we'll have everyone vote, and then I'll pull the votes during our report. We're actually gonna have two winners. So for first place, I have a little gift bag, big bag here for you guys. And then Miss Garcia is gonna be in around 3 o'clock, and she has 2 more gift cards for second and third place. Okay. All right, whoever wants to come up first. Looks like
Watch for the picture.
yeah, Shane on the stage.
Let me see. I don't know how to press it like. And I left the picture in the front too. Should we just do the pose of me like this? And the leader like this. And one. Wait, we're planning what we're gonna do. Enough said. Fireball.
Who else is in that row? Just go by row. Yeah, just by row.
Okay, Pete. I'll just put the Robert Lucas pants on.
So next.
Mr. Webb.
Yeah.
What?
Positive thinking to get you through this.
Where are we going, Alvin?
I don't know. Go through the polling. And that's it. And play music.
I'll just play the music.
Yeah.
I'll just be like, we're not telling anything. Enough said.
Dress up in this
Nice.
stuff.
Really?
Okay, let's go.
Okay. I don't know if y'all seen this movie.
Where's the moose at?
All right. You got it?
Ultrasonics.
I just.
Five difficult to reach vacations today.
Oh, I agree. Okay.
Where do you?
Where do you go?
Are you all like wireless?
No, CCS of a water. Basically, that would be like $20,000. Yeah. Us at the set, we're only about 800.
Anyone else? Did you get everyone? All right, perfect. So take one little piece of paper and pass it around.
I like the food.
And what I'll have
Oh,
you guys
I like
do,
the
once
football.
you break the names, I'll put it in the cup and then let's.
It's like, no, you just have to put my Instagram. Let's read all this stuff.
Shirts are down. I say we bring Mr. Worldwide up to the front and we play some kibbles.
Yeah.
Yeah, yeah, like, why not, right?
Yeah.
Anyone who likes participate, if you don't want to.
But here's once you vote for your person.
Chubby checker triple.
You want to propose?
Whoever wants to make a TikTok, then do that.
Let's go ahead and start it here. So, quick question for you guys, because they came up to me talking about Thanksgiving week. So from my understanding, it sounds like some of the other classes are getting shuffled up earlier in the day, is that right?
Yes. Is it?
Okay, so I would be totally fine with bumping my class up earlier as well, but the only caveat is that I need 100% of everyone being on board with it. If there's even one person that says, no, I'm not gonna do it, okay? So, do you guys know what time, Ross? And
She said that we could let her know, but I think she said we could be with her exam at like 8 AM and then once we're done with that, since we don't have clinic that day on Tuesday.
okay, so I'll basically be right after her.
Yeah.
Okay, perfect. So if she does hers, we'll figure out the logistics, but if she does.
That's
her
the
exam
exam.
at
That's the
8
next
a.m.,
farming
I'll
exam.
be to my class at 7:30.
Yeah.
No.
Oh,
I know she says farm's gonna happen first before Perry.
And. Yeah,
Or
well,
before
I'm
class.
totally, and if someone says no. So.
I'm good with
It's gonna fall off.
Okay, raise your hand if you do not want to move class early that day. All right, guys, we're moving class. I'll shoot you guys an email and I'll post an announcement.
So are we just gonna go for the Is that something we could do?
So then we'll review the findings next week and talk about it in class, okay?
Okay.
All right, so for today, we're gonna be talking about part 3 of our chapter 29, so surgical context here. So for today, we're getting into periodontal plastic surgery, okay? Now, periodontal plastic surgery is a very broad term that kind of encompasses a number of different procedures that you can deploy for patient care. So the main ones that we're going to be talking about today are tissue grafting. So we have 2 different types of tissue grafts that we can do. Free soft tissue grafts and substitutable connective tissue grafts. We're also going to be talking about displaced plaques. We talked a little bit last week before about apically displaced plaques. Today we're going to be talking about laterally positioned plaques, coronally positioned plaques, and semi-lunar coronal position plaques. And then the last 2 procedures we'll talk about are cornectomies and crown lengthening. Okay. All right, so periodontal plastic surgery. You guys will hear this term thrown around a lot. Mucogingival surgery. Okay, these are basically completely interchangeable terms. So if you ever hear the term mucogingival surgery, just associate it with periodontal plastic surgery. Okay. Periodontal plastic surgery is kind of more of a newer age term, so there's a lot of practicing clinicians that still use the term mucogingival surgery. Okay, it's a broad term encompassing a wide variety of different surgical techniques that we can deploy to manage the gingival tissue. So when we're talking about periodontal plastic surgery, basically what we're trying to do is we're targeting deformities within the gingiva or the alveolar mucosa and trying to correct them. Okay, recessions of deformity. So we can deploy these tactics for recession. Now, this is going to help to improve the aesthetics of the dentition. For example, in this image, you can see we have recession on 24 and 25. If a patient doesn't like the appearance of that, we can do a gingival graft, which is going to improve the appearance. We no longer have recession, right? So that's why we kind of came up with the term periodontal plastic surgery. But don't let that trip you up in terms of these procedures only being aesthetic. Because, yeah, they can be aesthetic in miniature, but at the end of the day, even if the patient was concerned about aesthetics in this instance, performing a gum graft is going to help reduce the risk of root caries as well. So most of the time, these procedures do have functional components to them as well. It's not strictly just for aesthetics, okay? But ultimately, most of the time, they do help to improve the aesthetics of these patients. Not like resective surgery where we end up getting recession. We're trying to improve the aesthetics as much as we can while also making sure the tissue again, teeth are still functioning. So it can enhance prosthetic dentistry, so anytime we're doing restorations, if we have to engage in mucogingival surgery, it can help improve the prosthetic. We'll talk about more when we get into crown lengthening. And then ultimately, we can also help to manage the damage from periodontal. If we have recession as a direct response to biofilm accumulation in this area, patient has periodontal disease, now we can go in and try and alleviate those before. Okay? All right, first thing we're gonna talk about is our free soft tissue autograft. What does autograft mean? From your own body. So same thing with our bone grafting materials. We have autografts. We also have gingival autografts. So basically, when you hear the term autograft, it's something from your own body that's being transplanted to another part of your body. Okay? So free soft tissue autograft. Who here has had a patient, or even maybe know someone, grandparents, aunt, uncles, anyone in your life that has had a gingival graft? What? One of you guys? What were their feedback on it? Did they hate it? Did they talk about how painful it was? My mom said it hurt. No one, but. So basically, the reason a lot of patients need gingival grafts is because they hear these horror stories of how uncomfortable it was, right? Especially when you're talking to someone that had a gingival graft years ago, and 15, even 20 years ago. The reason being is that back in the day, this was kind of our primary type of gingival graft that we did, the free gingival graft. And as you can see in this picture, basically what this involves, and we'll go over it in more detail here shortly, but what it involves is basically cutting a piece of the palate, like you can see in that upper right hand side, and taking that tissue and transplanting it wherever the recession is, right? But guess what? We can't suture this shut, okay? So basically what happens with a free gingival graft is it is an open connective tissue wound. And who here has burnt the roof of your mouth with cheese? Or hot coffee, right? Miserable, and it takes weeks to heal, right? Same exact thing here, only it's gonna be way more painful because it's in the liver, okay? So that's why a lot of patients, when you talk to them about gingival grafting, they might completely shut you down, especially if they're older patients. They might say, oh, I had that done 20 years ago, and it's the worst thing I've ever experienced in my life. Try and kind of calm them down in regards to that and let them know things have changed a little bit. So this is the older technique, which is still used today for certain cases. But the newer one, which we'll talk about on the next couple slides, is our connective tissue graft, which isn't as aggressive, okay? So I just want you to keep that in the back of your mind when you're talking to your patients and recommending gingival grafts. Okay, so let's get into our soft tissue graft. So this is also referred to as a free gingival graft, which you might have heard me go through there. And this was one of the first grafting procedures we ever deployed, which is why we've been able to improve upon it, right? Just like anything in terms of medical, if you look at how like the first surgery that was ever done, I'm sure it was a real big mess. That's compared to what they do now. Same exact thing. So this is very, very old school technique here. Now, when we're talking about any type of gingival graft, it's going to be usually indicated for areas of gum recession. Okay, we have recession present, patients having sensitivity, patient has a high risk of root caries, or maybe the patient just doesn't like the look of the recession. We can use it. Okay. Now, this graft is going to involve the epithelial tissue and the subepithelial soft tissue. When you hear the term subepithelial soft tissue, that just means connective tissue. Subepithelial was the tissue beneath the epithelium. Connective tissue, okay? Those terms get used interchangeably a lot. On my exams, they'll be used interchangeably, and on boards, they'll be used interchangeably. So always associate those words with each other, okay? So this is basically taking epithelium and the connective tissue, which makes sense when you look at this wound. We're cutting a square, sometimes even a rectangle, depending on how much we need, cutting a square to the soft palate, and we're lifting up all of that epithelium, and we're cutting away some of the connective tissue. Okay, so both of those tissues are tied into this. Now, anytime we're talking about gingival grafting, with the exception of one instance, which we'll talk about later, these gingival grafts are always going to result in 2 intraoral wounds. Okay, when we're dealing with autografts, it's always going to have 2 wounds. We're going to have the donor site, and the recipient site. So the donor site is where we got the tissue from, which 9 times out of 10 is gonna be on the palate. Okay, I've actually never heard of a gingival graft donor site not being on the palate. Okay, so we're very, very commonly pulling this tissue from the palate. And the recipient site is where is it going? Where the recession is at. Okay, well, as I mentioned earlier, that donor site is gonna stay open, okay? We have no ability to suture this shut because the tissue is so keratinized there. Okay, so basically we just leave it open, right? And what type of healing are we gonna get when we leave the wound open? Secondary, absolutely. So basically what we're doing is we're not able to get the wound edges close together. So we're waiting for granulation tissue to fill it. That's why this can take a long time. This takes weeks to heal, weeks to heal. So it can be very uncomfortable. And most of the time during the healing phase, what the doctor will do is sometimes they'll either put periodontal dressing over that wound, or sometimes they'll even fabricate like a retainer to put on the wound there to kind of cover it, to protect it. But even then, it's still really uncomfortable for people to go through, okay? So very, very, very painful, which you can imagine. Now, the other thing I want you to note with this type of graft is we are completely severing that tissue from its blood supply. Okay, completely severed from the blood supply. And that's something we want to take note of because blood supply is everything with healing. If we don't have active blood supply to the area, the site's not going to heal, right? It's probably going to get clotting happen, or we're going to get nutrients diffused to the area to make sure the tissue promotes healing. So we need to make sure that we have a blood supply. And so what ends up happening with this is because it's completely severed from its own blood supply, when we place it on the recipient site, we have to make sure that we're engaging in a technique to allow basically the recipient site vascularity to essentially merge with the graft site. And if that merging doesn't happen, the site will become necrotic. So it's really, really, really technique sensitive here, okay? So basically what they're doing is they take this tissue from the root of the mouth, they put it on a little piece of gauze to measure it. What they'll do is they'll kind of adjust the thickness if they need to, trim it down, basically making sure they have the right size that's necessary. And then they're gonna place it on this site, okay, which I have a bunch of videos and pictures to show you, okay? Now, when they're placing it on the site, like I said, they're really gonna want to make sure that they're suturing it in place properly, making sure it's staying immobile to allow those blood vessels to try and animals basically back onto the tissue site, okay? Very, very, very important. Always know that if you don't have a good blood supply, that tissue graft is not gonna take, it will literally just fall off. Okay, that tissue. Does that make sense? Okay. Super fun, right? And usually it's not an issue if you're going to a reference surgeon. They know how to make sure that they're getting adequate medicine out there. Okay, so our steps, basically what we're looking at here is we're going in and we're going to do vertical and horizontal releasing incisions. Okay, most of the time the horizontal incision is going to be our internal bevel. Okay, what they're going to do is they're going to do a partial thickness flap. Partial thickness meaning that they're leaving the periosteum over the bone. We do not need access to the bone for this procedure. We need access to the underlying connective tissue because that vascularity is kind of coming from. And so if you can place the tissue graft on top of the connective tissue, then that's going to allow for everything to heal and kind of diffuse the nutrients to the graft site. Okay. So we're doing the partial thickness flap with sharp dissection, which that just means they're having to use a scalpel to do this. Okay. They're going to remove the surface epithelium. They don't need that because basically what the graft is going to do is it's going to connect to the underlying connective tissue and it's going to create its own epithelial tissue. So they get rid of that. They cut it out. Okay. Just like anytime we're going in and doing any type of surgery, they're always going to debride the root surfaces. We're in there. Let's make sure everything's nice and clean so that way that doesn't cause any, ill effects on our post-op. Okay. Sometimes what they'll do is they'll prepare a template for this. So what they'll do is take almost like a little piece of foil or gauze and kind of size up the exact amount of tissue they need where the recession's at, and then take that template and put it on the roof of the mouth and kind of outline how much tissue they need. The whole point of the template is just to make sure there's not enough tissue. Because can you imagine if they cut a whole square out and then they're like, oh man, this is 5 millimeters too short. Now what do I do? That's why templates are used so much. Okay.
So, shoot.
So the graft is gonna be pulled from the donor site on the palate, and they're just gonna go in with sharp dissection. Again, sharp dissection is just a scalpel. And you'll see this in the video here shortly, okay? Then what they're gonna do is while that flap is pulled back, the connective tissue is exposed, they're gonna then take that graft tissue, slap it right on where the defect is. And then they're gonna suture it in place, okay? And during that suturing process, what they're trying to keep an eye on, you mentioned the blood supply. They're actually trying to make sure that there's no clotting happening while they're suturing this in place, okay? Because if a clot forms between the connective tissue and the graft site, it's gonna prevent that vasculature from infusing into the graft site. Eventually what happens with graft sites is they have the ability to form their own blood vessels. It's amazing what it can do. But the only way that graft is gonna be able to form its own blood vessels and nutrients and everything is if, you know, we have adequate adaptation between the connective tissue and the graft. And that's not gonna be possible if the blood clot is in place. Okay? And then basically what they do, very last thing, is they'll suture that in place. And suture the donor sites. They're just gonna cover that with a periodontal dressing. And most of the time they cover the recipient site with a periodontal dressing. Okay, which again, I mentioned last week, we'll talk about that in part 4. But basically it's just a protective covering that goes over the tissue just to hold everything in place. Because the other thing with these sites is we do not want them to move. If these grafts move during the healing phase, it can break apart any blood vessels that are forming and ruin the blood supply. Okay, so it's really important. Mobilization is really important for these guys. Okay. All right, so let's watch a little video here. Now this video, he's not going in with the intent to cover the recession that we see of the implants. What he's doing on this site is he found that the tissue was really thin around the implants. So it's just basically all around the big keratin. So you'll see at the top, the recession didn't change, but the thickness of the tissue. So just one more example of how we can, why we can use those grafts as well. See this one up here.
Just like sounds of makes me like there. Are those cracks?
It's like pop right off.
Yeah.
So what he's doing now is he's cutting off that
Oh, thank you.
All right. I'll have it this way. I'll have it right here.
And that's gonna stay all empty. It's gonna stay all empty, like open. I'm gonna put it right down. Kind of. No, they don't. My old high school teachers, dog got like attacked by another dog. It was a big dog, but I think it got attacked by a pit bull. And that's like what the side of her belly looked like. So it like bit all over it. And she lived, but it was like, it was a lot.
All right, we're going to another thing.
How?
Really important to make sure it's important.
It's like when I'm kidding, I've seen it.
Yeah, no, like there, not in that.
Large.
Hey, Okay, so now he's gonna suture this graft in place.
Maybe can I just hold my pen up?
They go,
Like, what do you feel like have to do it for the first time? Like, okay, go do it. Do it on a person.
be better off. Really closing this into place there. And that was basically it. So what's gonna happen is that's it. He doesn't have to pull the tissue back over and cover it at all because that's epithelium that's exposed, right? Remember, he took the epithelium and then the connective tissue. And so connective tissue from the recipient site contacts the connective tissue from the graft and the epithelium is on top. So we don't need to pull that flap back down. That's why we end up cutting away the epithelial tissue. So we don't need it anymore. And what's gonna happen throughout the healing process is hopefully that graft is gonna be developing its own blood supply. It's gonna fuse with the connective tissue underneath. And then eventually that epithelial tissue is gonna slough off and it's gonna create new epithelial tissue. Over the course of 3-4 weeks. Okay? Right, really. So questions on that? Okay. Okay, so healing, like we mentioned earlier, that donor site is gonna heal via secondary intention. It's gonna utilize granulation tissue to close up. The recipient site is gonna heal via primary intention. We are placing sutures. So again, anytime you're asked a question of what type of healing is at play, think if sutures are placed or not. If sutures are placed, you don't even need to think anymore. That's your primary, okay? Like I mentioned earlier, mobilization is key. They have to suture this in place to make sure it stays in place. And most of the time you'll put periodontal dressing over the top of it to lock it in place as well. Like I mentioned earlier, if we are moving around while it's healing, we're not gonna get diffusion of nutrients. We're not gonna be able to form new blood vessels because whatever was forming is now broken. And it can cause a lot of issues with healing, okay? So the survival of any type of graft, whether it's this graft or the connective tissue graft that we'll talk about next, really relies on blood supply. Even when we're doing displaced flaps, if we sever the blood supply, that flap is going to become necrotic. So it really is an important component of surgery. So it's going to depend on the vascularity of the recipient bed and the growth of new blood vessels. Okay. We have to make sure that the underlying tissue for where we're placing the graft has good vascularity, and then we also need to try and do everything that we can to ensure that the graft creates new blood vessels over time. Okay, like I mentioned earlier, the epithelium is going to eventually slough off and create new epithelium. Epithelium is constantly turning over, so that guy is able to heal up pretty quickly. Now, the main well, there's two main downsides of this procedure. We talked about the pain, right? That open wound on the palate. The other downside is this can result in a tire patch appearance. Who here has worked on a patient in clinic and you were able to see where their graft is from? A couple of you guys? Perfect. So with this type of graft, it doesn't really produce the most aesthetically pleasing end result. And I have some pictures coming up to show you what that's going to look like, okay? And it's just strictly because of the type of tissue that we're using and how we're engaging in this procedure that ends up resulting in this tire patch appearance, okay? So if you see something like this on a patient, okay, any of these, this right there is stereotypical pregingival graft, okay? And that's why if patients are engaging in this procedure to improve aesthetics, they might not be super happy with this outcome. Which again is another reason why a lot of surgeons have kind of deferred away from the gingival graft, pregingival graft, and went into a connective tissue graft, which we'll talk about. Okay, so this is not a work answer. Don't freak your patient out. Strictly gingival graft, stereotypical gingival graft, and you'll see it very commonly around the anteriors too. Like when you guys were working in clinic and you had these patients, where'd you see it? Mandibular anteriors, maxillary anteriors.
pigmentation, so you
Okay.
can tell that it's only on the side of the log on the sheet.
Okay, you should look at that out of there, all right. Where was your patient? It looks exactly like your middle. Love it, right, perfect, okay, so I'm not being dramatic when I say this is how it's gonna look. And truly, this is how it's gonna look. Okay, totally normal, nothing very critical to do about it, it's just the nature of the procedure. Okay? But the good news is that tissue is very nicely healed, and that's a lot of keratinized tissue right there too, it's very thick. What was that?
I'd rather that.
Exactly, right, exactly. Okay. All right, so here is a breakdown of what this guy looks like, okay? So here you can see we have the tissue graft placed. This is not a membrane, this looks like a barrier membrane. That is the tissue. The reason it's so white is because there's no blood supply up to it. Tissue is kind of a whitish, yellowish color, there's no blood in it, okay? So you can see that that graft site is fully exposed, okay? This guy here, I want to say, is 1 month post-op. Okay, you can definitely see we have some good amount of healing there. This is the surgical site, the donor site, 1 month post-op. And this is 1 year post-op. Okay, you can see there's still a little recession there, right? But definitely way better than where it was even after 1 month. Okay. So here's that really good picture of before and after as well. So here's your before for 24 and 25. You can see 3-4 millimeters of recession there. And here's the post-op. So again, we probably still have 1 millimeter of recession, but it's night and day compared to what it was. Okay. So the reason I show you this is it's really important to make sure that patients' expectations are on par with what we can do. When we're recommending gingival grafting, we're not going to tell them, oh, all of your recession is going to be covered. It's going to be perfect. Everything's going to go back to 100% normal. That's our ultimate goal. But at the end of the day, the patient's body and the healing response has a lot to do with how it feels long term. So we never want to go in and set the patient's expectations for their gingiva to be completely covering these roots. If we can get 2 millimeters of root coverage, that's a win for surgeons. Okay, so it's not always going to be 100% predictable in terms of how much root coverage we're going to get. Okay, so going back to those patient expectations, that's a big part of surgery. Okay. Questions on the pre-gingival graft? Okay. How are we doing on break? Do we want to do a break or get through the connective tissue graft? All right. Okay, so the next one is our subepithelial connective tissue graft. Okay. Subepithelial is also connective tissue. So again, the words go hand in hand. Okay. Now this guy is more common of what you're going to see with patients that are currently undergoing surgical intervention for grafting. Just like the pre-gingival graft, we're going to use this for gingival recession. So if someone's unhappy with the recession that's present, with sensitivity, with food decay, we can do this graft. Okay. Or like we saw with that implant case, if we're just worried about getting more keratinized tissue in the area, we can also do this for that as well. Okay. Now this one here only involves connective tissue. Okay, we are not utilizing surface epithelium from the donor site. We're just gathering connective tissue. So that's one of the main differences between this and a pre-gingival graft. Okay. We still have 2 intraoral wounds. We still have a donor site and we still have a recipient site. The donor site is still going to be the palate. But what you'll see in the coming pictures and videos is that it's way less invasive because we're basically just creating a little line in the gingiva, a little incision in the palate, and basically cutting away the connective tissue underneath. And then we have the ability to suture that with a cup. So it's still a wound on the palate, but it's not an open wound, which is why it's usually not as painful. It's still going to feel like patients have a burn on them, right? It's still going to be uncomfortable for a couple of weeks. But compared to the pre-gingival graft, it's night and day. Okay. So if you have patients that are really worried about the feeling of it, especially if they have experience with the other graft, let them know they can talk to their surgeon about doing a different type of graft that's not as invasive. There are options out there. Okay. So the steps here, basically the same exact steps, just minor differences here. So we're going to do horizontal and vertical incisions still. Now with this horizontal incision, it's going to be the clavicular incision. We're going to go into the sulcus there. Okay. They're still gonna be engaging in the partial thickness flap. You don't need to get all the way down to the periosteum. You're not doing anything with the bone. So basically just a partial thickness with a sharp dissection, AKA scalpel. Debriding the roots like we always do. They're gonna take the graft from the palate. And basically what they're doing is they're excising through the epithelium, like I mentioned earlier, to get into that connective tissue. And then they're cutting away just the connective tissue. And then they get to suture that guy back up. So that gets the primary intention. Way better for patients. Okay. The graft is then going to be placed underneath the partial thickness flap. And then it's sutured in place. Okay, so this one's not going to be as exposed. The other one, the pre-gingival graft, that epithelium from the gingival graft is completely exposed. This one's going to be covered by the patient's epithelium. Okay, we're not going in with the intent of cutting away that epithelial tissue because we need it, right? We're not grafting something with epithelium, we're just grafting connective tissue. So lifting up the tissue, packing it underneath, and suturing it back up. Okay. Periodontal dressing is still going to be used here as well. Most of the time with this procedure, they don't really have to place a dressing on the palate because it's souped up and it does heal pretty nicely. But they'll definitely place it, most commonly place it at the recipient site, again, just for immobilization. You don't want it moving. Okay. Let me show you a quick little video here just to kind of summarize what that just was, and then I'll show you more videos that are coming up. Okay. Here they're going in on the palate. And notice the difference in incisions. Teeny tiny little rectangle. So they're gonna start severing the connective tissue. It obviously doesn't come out that nice. Pull it out just like that. So they're only taking about a millimeter of epithelium. So because the wound is so close together, we can suture that. It's not a big wound, we're able to suture that tissue there. Yeah. Yep. Yep. Oh, it's pretty straightforward. So there's our vertical incisions there. Flapping that tissue back. So placing the graft underneath, suturing it in place and closing everything back up. Now eventually that feels good. Okay. Now, because we're using the patient's own epithelium, we're not trying to grow a new epithelium or anything like that. That's why this improves the aesthetics way more than a region. We really don't see that tire patch appearance with this guy. Okay. So here are some pictures here for you. So this guy is for tooth number 10. So up here in this upper left-hand side, you can see probably 3 millimeters of recession at number 10. And kind of notice how the gingiva dips in a little bit. We kind of have a little bit of a depression on the gingival tissue, which usually tells us that it's lacking connective tissue underneath. Okay. So this one not only is going to improve the aesthetics, reduce the risk of caries, sensitivity, but it's also going to build up that connective tissue underneath. So it's more cohesive, more even. Okay. Then they're going to flap the tissue back, this bottom picture right here. So you can see the 2 vertical incisions, and that clavicular incision just goes underneath the sulcus to pull back this tissue. Notice how the gingival papilla is still intact. So we're not cutting that stuff away. We're keeping that. Okay. Once that periosteal tissue is exposed, the connective tissue is exposed, we place the graft in place, and then suture it up. Okay, so you can see everything. You can't even really see the graft in this image because they completely sutured it over underneath the flap. And then here is the donor site as well. So again, it doesn't look the prettiest. They had to take a pretty big chunk of tissue out of there, but it's sutured in place. So yeah, it's going to feel like a cut on the roof of their mouth. It's going to feel like a burn, but way better compared to, okay. So the healing here, because both sites get sutured in place, we're looking at primary intention on donor site and recipient site. And like I mentioned, we really tend to get really good aesthetics with these. Okay, they're able to really kind of coincide with the pre-existing color of the tissue. So this here is actually the post-op. So you can see that recession is completely covered. right? Maybe 1 millimeter still exposed, but comparatively to what it was, we're completely covered. Now, it's still not as smooth as the natural contour is. And again, that's why we always spend, especially surgeons, will spend time going over patient expectations. You know, this is what we hope to do, this is what we hope to accomplish, but it's not always gonna be textbook perfect, right? The healing phase has a lot to do with what's going on, okay? So here's that comparison for you, show it a little easier, so you can see, we probably got 2-3 millimeters of root coverage there. So night and day, night and day. And over time, this papilla may kind of stabilize a little bit more as well and kind of even out. But at the end of the day, that might also just stay as is as well, okay? You can have the perfect surgical technique, but if the patient's body decides to do whatever it wants during the healing process, there's really not much to do. Okay? And this image actually is only 6 weeks post-op as well. So this is a little over a month post-op. So that's pretty good healing for a month's time, right? Now, there are instances where we can use allograft material. What does allograft mean? Another donor, right? So allograft is from someone else. So they do have allograft material for gingival grafts. It just depends on the surgeon, whether or not they have that incorporated with their procedures. And it also depends on if the patient would be willing to have that done. There's a lot of people that are not okay with having cadaver tissue placed in their own body. There's a lot of coaches that aren't okay with that as well. And so it's something to really be cognizant of. But this can be an excellent alternative for patients that are like, I don't want to go through the pain of my roof of my mouth, okay? With these procedures, I know I've talked a lot about the discomfort on the palate. The recipient site doesn't really hurt. Okay, it's a little uncomfortable, it's a little sore, but the majority of the pain from this procedure comes from the roof of the mouth. So if your patient's really hesitant on it and they're like, you know what, I've even had the connective tissue graft done, it's still miserable, I don't want to do that again. Maybe they can talk to the surgeon about using allograft material. Okay, so this is going to be harvested from a cadaver. Just like we mentioned with the bone grafting, it undergoes a very rigorous screening process and sterilization process to make sure that we're not transferring any viruses or diseases. Okay, so they're going to treat it to basically remove all of the cellular components. So essentially, it just kind of almost becomes a matrix for the tissue to build on. So it is going to contain blood vessel channels, which is really nice because once we place that tissue, the blood vessel channels are already there, so it's just up to our body to kind of fill them in, okay, which is perfect. That makes the blood supply go really, really well. Collagen, it's gonna have some collagen in it, elastic as well, which is perfect for our connective tissue and proteoglycans, okay. Basically, what these grafts do is they just stimulate the recipient site to move its own tissue into that area, okay. Kind of like the scaffolding effect that we see with some of our bone grafting materials. Very similar concept, just with tissue. Okay. So the benefits of this is obviously on one side, we're just managing the recipient site, which is not perfect. There is an unlimited amount of donor tissue as well. So it's not like someone needs to be put on a transplant list for a heart in maybe 3, 4, 5, 10 years. Okay. There is so much donor tissue out there that we don't even know what to do with it. So unlimited supply, which is great. And again, it's going to be having improved patient acceptance as well because we don't have that thalamus. Okay, so patients really do appreciate having this alternative for sure. Okay. All right, let's take a 5-minute break. Let's come back at 3:20 and then we'll watch our connecting meetings. Okay. 3:20.
Yeah.
Yeah. Oh, yeah, it's the really. I know a little brother. I know you're right. You might win and you get the bag and there's a close. Yeah, you can help out.
And tomorrow. Our country.
Do you have a ride or?
No. Yeah. Oh. Oh. Yeah, last time I went by myself. It was okay. Yeah. And then I rode the Lila.
Oh, the Lila. Oh, the last time, yes, the Lila gave me a ride.
Yeah.
But no,
North Country.
oh. No, we went to SNC with the.
Oh. Yeah.
Actually, I just tried it.
Thoughts?
That's my favorite.
Oh, you know.
Oh, I'm sorry.
Yeah.
Three-ish, four-ish.
And the short functional stability.
Why did that make Leo the June?
You look great now.
There you go. I like it.
SZA.
2 days from now.
You listen to SZA? Is he naked again? What'd you say? I said, do you like SZA? Listen to her. It sounds like a lot of radio. Not Ethan. That's also a popular costume. Also, Ethan looks so short. These heels are not even big. There. I like it when all of our trees on. They're just so funny together. Sometimes I can't even tell if they're playing characters or not. I'm like, are you still playing a character or is this super? Plus, they look the same. Look at me.
You finally took off the haircut in the last episode she was on, right?
Yeah, I had like the blonde one. I had like blonde hair.
Yeah, but you like.
I think so. Oh, shoot. Oh, don't.
I don't know.
Yeah.
Yeah. They're all half on.
Yeah. Yeah. At the same place. Yeah. You guys to figure out how you want to do it. So nipples, roll up.
Bulls.
They won't.
If I ever Jonas Brothers after. Good boy. He's a singer. I forgot we're still. Oh, yeah. That's like people. There's good too.
You are the naturally racist.
See? Wait, what's in there? Here, that's our thing move. Okay, so now we're gonna watch the video here for the top teaching graph. I believe that my memory is not great, but same 90s video from last season in the lobby.
The next procedure is an aesthetic root coverage surgical procedure for the primary purpose of exposed roots and increasing the band of healthy detached tissue in areas where recession has occurred. This type of mucogingival surgery is referred to as a subepithelial connective tissue graft. In this procedure, donor tissue is harvested from the patient's palate and grafted over the areas of recession. Besides using connective tissue from the palate, some clinicians use barrier membrane, other sources of connective tissue from the patient, or tissue from tissue banks. There are many other soft tissue graft procedures available, but this one will be the only one discussed today. This is generally a very predictable procedure. Soft tissue grafts are performed to cover exposed roots caused by recession and to increase the band of healthy attached tissue. Indications for performing this procedure include recession or mucogingival defects on teeth, recession with root sensitivity, and recession caused by the placement of a restorative crown. There are some situations when a soft tissue graft may not be appropriate. These contraindications may include insufficient donor tissue, gag reflex, large tongue, or other impediment to palatal access, poor compliance by patients in the past, or extremely prominent roots. Smokers should be carefully assessed and counseled, but not necessarily excluded from these procedures. We will now show the surgical procedure for the soft tissue graft known as a subepithelial connective tissue graft. The case that will be presented is rather complex due to the multiple teeth that are involved. As you can see from the patient slide, there is a freedom pool above the canine and the first bicuspid, loss of papilla between the first and second bicuspid, and recession that measures 4 millimeters by 5 millimeters on both the canine and the first bicuspid. These recessions are fairly wide, and you can see that they are progressive. We see here that the attached gingiva is approximately 2 millimeters in the area of the first bicuspid. It is approximately 1.5 millimeters in the level of the canine. We can also observe that there is plenty of attached gingiva on the lateral. These are the primary incisions. The surgeon is first making a vertical incision just distal to the premolar. Horizontal sculptural incisions are now performed in the interproximal papilla areas at the level of the corresponding teeth to mental enamel junction. The vertical incision delineates the surgical area of treatment. The periodontist wants to preserve as much of the papillary tissue as possible. The incisions are made perpendicular to the tissue to maximize blood supply in the papilla area. The key for the success of this soft tissue grafting procedure or any other is to maximize the blood supply to the graft. The surgeon is now creating incisions in the palate to harvest the connective tissue, which will be the donor tissue used to cover the exposed root surfaces of the teeth in the surgical area. An incision is made approximately 2 millimeters from the most lingual aspect of the teeth to the length needed for the surgical recipient site. In this case, it was quite large due to 4 teeth being covered with one procedure. Another horizontal incision is made about 1.5 millimeters parallel to the original incision. The purpose of this incision is to keep the epithelial collar to aid in suturing. There are many other techniques used today which do not include the epithelial collar or vertical incisions. The donor tissue is carefully dissected from the flap and the underlying bone. Knowledge of the palatal anatomy is crucial when performing this procedure to make sure there are no large blood vessels involved during the procedure. As you can see, the periodontist is carefully removing the tissue to ensure a uniform thickness of graft and minimal disruption to the surrounding tissue. When harvested, the periodontist places the graft on a firm, sterile surface for evaluation and to create a uniform thickness if necessary. The surgeon closes the palate immediately, in this case, using natural sutures. Careful suturing is necessary to aid in blood clot development. The suture aids in approximating the tissues, but also provides the needed pressure to ensure adequate fibrin clot formation to control the bleeding. Here, the periodontist is placing the connective tissue that has been harvested from the palate onto the graft area. It's important to be sure that the graft sits passively in the surgical site and minimal space exists between the graft and the recipient bed, which could interrupt the healing and attachment of the graft. The graft is now being carefully sutured in place to ensure a successful result. A lot of time is spent suturing because intimate adaptation of the graft to the recipient site is critical for success. When the graft is adequately sutured, it is important to be sure that the flap is passively positioned coronally to cover the soft tissue graft and recession. This is done to ensure that when the patient smiles, before the site is fully healed, the flap will not be pulled away from the surgical site. This is critical in the adhesion of the graft because the success of any graft, be it bone or soft tissue, depends on how immobile the graft is. The blood supply has to reanastomose or connect to the supporting structure. Here, the periodontist is suturing through both the papilla and the overlying flap. The connective tissue graft is now sutured into place underneath the flap. It's stabilized, and we are looking at a band of epithelial tissue. You can see the surgeon pulling the overlying flap to position it coronally. The tissue should be sutured as far coronally as possible. You can now see the surgical area is completely sutured. The roots are totally covered with both the graft material and the overlying flap. As previously mentioned, blood supply is critical for successful grafting. You can see that the graft is mostly covered by the overlying flap for this reason. Let's look at another case that will benefit from a soft tissue graft. This patient exhibits severe cervical abrasion, which can be successfully treated with the technique we watched today. This before slide shows significant recession that is deep and wide, and the root surface is set back from the enamel surface. This photo taken following soft tissue graft surgery shows complete recovery of all teeth in the surgical site. Post-operatively, you see significant coronal coverage of the root, and that the abrasions and indentations in the root surfaces have been covered. Again, this soft tissue graft procedure was performed primarily for the purpose of aesthetics, but also performed for the purpose of reducing root sensitivity. In addition, you'll see significant improvement in the patient's smile line. 100% root coverage on all teeth involved in the surgery, and a wide, healthy band of attached keratinized tissue has been obtained. The result is aesthetic with an obvious increase in the zone of attached keratinized tissue. This surgical example illustrates the intended outcomes of soft tissue grafting quite well. Those expected post-surgical outcomes include improved aesthetics, coverage of exposed root surfaces, the elimination of mucogingival defects, and adequate keratinized attached gingiva. In summary, soft tissue grafting procedures are performed for the purpose of improving aesthetics, reducing root sensitivity, and preventing further recession. Patients describe the discomfort associated with the donor site as being similar to a pizza burn. Over-the-counter or prescription pain medications and ice application is usually all that is necessary for patient comfort. Patients should be instructed not to brush in the area for approximately 2 weeks. No special maintenance is required for most patients undergoing soft tissue regeneration for aesthetics. As in all cases, the treating clinician's recommendations are used to determine the best frequency of recall.
But that would finally.
Let's discuss a patient that we
All I got for you on that one. What are your thoughts on the connective tissue graft?
I'm a fan of the connective tissue graft on the free graft.
It's way better.
The whole thing is in like.
For the palate? Oh, the recipient site, absolutely, yes. Because anytime they're placing a graft, they want to make sure it's sutured in place regardless of the type of graft. Because if it moves at all, that's gonna.
Because that was in my group, like a thing,
So
she
they
didn't
suture
get
all grafts in
info
place,
for
just to make
discussion.
sure it's stabilized, that way blood flow can kind of get back to the area. Yeah, they plot that over top of it as well.
Oh.
Yeah, basically they'll suture the connective tissue in place. You're thinking of the free gingival graft. The free gingival graft, they don't have to suture anything over top of it, they already remove the other. Other feelings gone in that one, so the tissue graft is just exposed, so once they suture in place, that's it. This one, they put the connective tissue underneath, pull it flat down over top of it and suture it all in place. Yep, great. All right. So now let's get into this lace flaps. Like I said, we already talked about the lace flap. Next one we're gonna talk about are lateral position flaps. Okay, so these guys here can be a really good way to cover localized areas of recession. Okay, very, very, very localized. Essentially what we're doing with this, you can see in this image. When we have, let's see, gingival recession here on this tooth, right? Is that tooth number 8 maybe? Okay, and what they're doing is they're gonna cut a flap around tooth number 7 and pull that over to cover tooth number 8. Okay, and what that's doing is that's gonna leave some of the tissue still covering over the donor tooth. It's still gonna leave some of the connective tissue there, so basically the epithelium will eventually move back in and pull it to cover this area. Okay, so the caveat of this type of positioning here is it has to be adjacent to the recipient site. Donor site has to be adjacent to the recipient site. And not only that, but the donor site also has to have thick enough tissue that we can do a split thickness flap, cut it in half basically, and pull half of that connective tissue over to the adjacent site. Okay? So this can be a really good alternative for patients again that we don't want to do a gingival graft. For whatever reason, they don't want to do the allograft material and they are too worried about the donor site on the palate. This is a good alternative. So even though there's a donor and recipient site, it's all kind of in the same area, right? It's going to be 2 teeth right next to each other. The good thing about this type of laterally positioned flap here is that the graft is going to maintain its own blood supply. We are not, notice the little lines here, we're not cutting this out completely. So this is still connected to the underlying connective tissue. It's still having its own independent blood supply, which we love for healing. Right? We talk a lot about the importance of blood supply. So that's a really, really nice thing about this type of graft and flap surgery here. just like any of the other surgeries we're engaging in, this one's also gonna be sutured in place. Which makes sense, because if we didn't suture it in place, it's just gonna end up falling right back to where it was originally placed at. Okay, so we are looking at healing through primary intention for the recipient tooth. Okay, donor tooth is gonna have a little bit more healing of secondary intention, just because we're pulling that epithelium away from it. So the connective tissue is kind of exposed. Okay, and the recipient side, I want you to know, heals with primary intention. And then as with everything else, we do have to place periodontal dressings over this area as well. Because not only are they sutured in place, but we want to really make sure they're not moving. So we'll slap some of the periodontal dressing heavy over top of it, hold it in place. Questions on the laterally positioned flap? Straightforward there, right? Coronally positioned. So this one here is another option for us to cover recession as well if patients aren't coming to go through a full-blown graft. So we can predictably cover about mild to moderate areas of recession for about 2 to 3 millimeters of recession. We cannot do this type of surgery on a patient with, severe recession, 4 millimeters, 5 millimeters. There's not enough tissue to pull down and hold it in place. So it's really just for mild to moderate areas of recession. And what they're doing is basically taking the tissue, making vertical incisions in it, like we just saw, and pulling it down. Okay, so the nice thing about this type of procedure, if the patient is a good candidate for it, is there's only one surgical site. There's no donor site either. The donor tooth is the recipient tooth. All we're doing is just pulling that gingiva down. So it's a really good alternative for the localized area of the recession. But again, just like that laterally positioned flap, we must have enough periodontal tissue to accomplish this. Because if not, if there's not a thick amount of keratinized tissue here, what's gonna end up happening is we can suture it back into place, but over time, it's gonna end up receding right back down. Okay, so the amount of keratinized tissue is really important for us. Okay. This one is a little bit more tricky to stabilize as well, usually requires way more sutures and will involve the periodontal dressing as well. But ideally, because we're suturing in place, we're gonna get that primary intention. Okay. Questions on that? Yeah.
It's something like able to lie as much as
Yes, exactly. Like this one, if there was, let's say, recession on tooth number 6 and 7, it's probably not going to be a coronal one for it. Yeah, usually these two, this one and the lateral one, are very localized there. Sometimes they might be able to swing too, but.
Maybe I'll
Any
just
other
do them right
questions on
now.
this one? All right, semi-lunar. So lunar position flap. This guy here is basically a variant of the coronal position flap. Okay. So same thing, really only using this for mild to moderate areas of recession. We're not going to be trying to use this flap with severe recession. Okay. Just like the other flaps we mentioned, it's going to require enough keratinized tissue. Okay, to make sure we're not going to once we're done. And you'll see, basically what they're doing is they're making incisions apically on the tooth. Okay, so they're not cutting any of the curricular tissue here. They're incising a scallop incision up top here, kind of like our internal bevels. Okay. Once that tissue is then exposed, what they're going to do is basically pull that tissue down. And it's going to result in root coverage with exposing some of the connective tissue up here, the apex. Okay. Now, what this one ends up doing is it's very, very predictable in the coverage as well. It's a little less invasive. And this area here is able to heal with our secondary intention. Most of the time, we're not going to be suturing up here. Most of the time, once they pull that tissue down and apply pressure to the tooth, it actually stays in place really nicely. So we usually don't have to get too aggressive in our post-op placement of sutures and things like that. They definitely can stabilize with sutures if they feel it's necessary, but it just totally depends on the patient case. So essentially, we're still pulling it coronally, but instead of cutting all of the capillary tissue, we're cutting the tissue up near the apex and pulling it down. Okay. Questions on that one? All right. Frenectomy now, let's get into our frenectomies. Now, I know you guys have already heard a lot about frenectomies already, I can like just what we can use them for, so I'm gonna kind of go quickly through some of this, and I'll spend more time when it actually comes to the actual procedure. But basically, a frenectomy, we're removing the breast, okay? Now, be cognizant of different terminology with this, so we have a frenectomy, and then we have a frenotomy, okay? These are two different terms that sound very, very, very simple. So a frenotomy basically is going in and excising the frenum, but it's actually not removing the attachment from the bone. So you'll see in the videos that I'm gonna show you, that frenum has fibrous tissue that actually extends into the deeper periosteum, okay? It's extending onto the bones and latching onto the bone. So with a frenotomy, they're just going in and excising this little piece of tissue here, but they're not going deep. Frenectomy, they're cutting this tissue and actually opening it up to expose the fibrous tissue that's connecting to bone underneath, and they're removing that as well. So frenectomy is, I'm gonna say it's a very involved procedure, but you'll see with our current techniques we use, it's actually a really straightforward procedure. But they do need to get to that bone and cut away that tissue. Because if they just engage in a frenotomy and just cut this tissue away, just flip that right there and call it good, that frenum's gonna come back. Because the fibrous tissue that's underneath the gingival tissue, the alveolar mucosa, is gonna start regenerating some gingival around that. Okay, so the true frenectomy, we need to cut away that fibrous tissue, otherwise it's just gonna come right on back, okay? Now, frenectomies can be performed on any frenum. Okay, we have multiple frenums throughout our mouth. Most commonly, you're gonna see these on mandibular and maxillary septal frenums, okay? That being said, I've had patients that have frenums near the premolar area, and you can see on the face, but it's more common on the anteriors. Now, the other thing with frenums is patients that are edentulous might need a frenectomy as well. Okay? Because if you look at this patient here, this is their maxillary arch, and we have two frenums that are coming in right near where probably 89 would be, right? You can imagine that if their denture is placed over top of this, the denture is going to impede on that frenum, and it's going to be very uncomfortable. Anytime the patient coughs or moves their lips, it's going to readjust their denture, which would be really important. So just because a patient is edentulous does not mean that we should just disregard their frenums. Okay, because it might be an issue for their dentures or even their partials, okay, the partial dentures. So keep that in mind as well. When we're inspecting our patients that have dentures, look for frenum holes, ask them if any areas are uncomfortable, okay? Now, this procedure can be done with either a scalpel or a laser. So I'm gonna show you both techniques today. And I'll be completely honest with you, the scalpel one is gnarly. It is gnarly. The laser one, okay, so most offices that do frenectomies, you don't really have to go to a surgeon for this. There are a lot of general dentists that are comfortable performing this procedure as well. And a lot of them have lasers in their office now, right? So most of the time frenectomies are done via laser, but I'm gonna show you both, I'm gonna show you videos of both so that you can kind of get a good idea of what goes with them, okay? So the steps basically, this is the steps for if we're performing a frenectomy with a scalpel. Once they get the patient on, basically what they do is they grab hemostats and grab hold of that frenum. Okay, and then what they end up doing is making two incisions on top of where the beaks of the hemostat are and on the bottom of the beaks of the hemostat. Okay, and basically once they make those two incisions, the frenum is made loose, right? They cut top and bottom, so they just pull out the tissue. And then that's gonna leave a big open wound that they go in and make sure that they have all of the other fibrous tissue removed. And then most of the time they'll suture it up. Okay. And then sometimes they'll place a periodontal dressing. It just depends on the patient case as well as that one. So here is an example of a scalpel frenectomy, okay? And again, I have a video I'll show you. So same picture we were seeing earlier, tooth number 25 has a pretty bad frenum hole, which is resulting in recession. So what they did is they went in, grabbed that frenum with the hemostats, clicked on the bottom, and clicked on the top, and pulled it out. And when they do that, you can see how wide it is. Okay, it's very, very big deal. Now, most of the time they suture that high. Same thing with these frontums over here, they probably use two different hemostats, rather than one, maybe top incisions, bottom incisions, and then suture down. Okay, yeah.
Does this ever qualify, that?
Sometimes, most of the time they like to split it into separate. So, if this is basically if they were to go in and try and flap this tissue back, they're really only gonna have about 2 millimeters of tissue to flap back. It just wouldn't, I think it would improve on the
That's what I mean, like, do they still undergo that procedure?
They could, it just depends on the patient. So if the patient's worried about aesthetics or if they're sensitive in that area, then they need to press that. That's very funny. All right, so let's watch some videos here. I have a feeling this is gonna make the video too. This one's later. All right, so this one here is.
Well, today we're going to talk about maxillary anterior frenectomy. You can see the big frenum right here. And the feeling was that this would affect the comfort of the maxillary denture. I just placed small diameter implants in bone graft. But you can see how far the denture would have to be cut back, and this would be a real rubbing area. I'm first placing two curved hemostats. One hemostat is curved, is placed in the apical part of the frenum, the part toward the nose. The other hemostat is placed like this, adjacent to the alveolar process or adjacent to the tissue, so they look like this. This is planting the bottom part of the frenum, and this is planting the top part and the meat of the tip. And then I'm going to cut here. Just let my blade slide along the hemostat, and then I'm going to cut here with the 15 blade until it meets the cut where the two hemostats connect. And then this piece right here, the frenum, is going to come out of the mouth with the hemostats, and there's going to be a big hole in the tissue right there. This is my 15 blade real quick. You just cut right along, touching the hemostats, and they'll meet right here, and this piece will just come straight out. Very important that you use curved hemostats when you perform a frenectomy. You just cut it freehand, it's gonna open up, like you cut a hole and float up your lung. You're gonna go, whoa, where am I? You can get lost. So if you place the two hemostats and then cut around them, touching the hemostat with the barbed part of the blade, it will be a perfect frenectomy and you won't get lost. This is easy to suture in the non-keratinized, unattached tube. You can't pull the flap together with keratinized, attached to it, it's condensed, but you can approximate the flap in the non-keratinized tube. It's oral gut suture, it dissolves in 3 to 7 days, and that's just perfect for this. Immediately after implant placement, teeth extraction, and frenectomy. This is after 2 weeks of healing. Isn't it amazing how fast the oral cavity heals? And that's the good method.
It's like naturally from the.
Now, the next show you is gonna be
When
a
just-
diode laser. So this is the one, diode lasers, and you guys might find this in your research.
Oh my gosh.
For periodontal therapy. So diode lasers, if you end up getting laser certified, you'll be certified to use diode lasers. Now, with lasers, you'll hear this dentist or surgeon talking about different wattages. So yes, this is the laser that we can use, but this is not a wattage that we're able to use. You can't use a laser that's gonna cause permanent irreversible damage. This is obviously irreversible, right? So we can't engage in this. This is for dentist only, okay? But this is definitely the same type of laser that we can use. This laser, I think he's using a Picasso laser, if I can recall. And I've actually used this in private practice as well. So see if this will go or if it's gonna redirect it. All right, let's look at
It's fine.
You wanna bring it up, so she'll actually have a fuller upper lip when we're done. And also with the attachment of the cranium right near the pupil between 8 and 9. You can actually close this gingival embrasure slightly because we eliminated those fibers from pulling every time she smiles. So we gave her a local injection, just used about a quarter of a cartridge of lidocaine.
Just
I like to use these Ultragates, these are available from Vivaclar. It's a non-latex, flexible cheek retractor, open for me. Has a stiff inner ring and then a stiff outer ring. It's non-latex, so you can utilize it with non-latex allergy patients. How are you doing? You okay with that?
Lily, when we went to the parade.
Be sure to tell me if you have any discomfort, you know, to use any anesthetic. Again, we wanna make sure we have laser eye protection. And as long as I look through my loops, I have caps for an 810 wavelength diode laser. All right, so we're gonna go ahead and use the diode in the cutting mode, somewhere in the 1.2 watt, again, this is touch screen. We can either raise the wattage or lower the wattage depending on how the cut is being made. The diode laser is attracted to dark pigmentation, like melanin. So a patient that has a lot of melanin, Black American, Mediterranean, we typically would have lower wattage or lower energy used than someone that is light-skinned or most Caucasian. Again, the goal is the least amount of energy to do the job. As I start making my cut, if I'm getting a lot of laser char, which is almost like a black deposit, a carbon deposit, then we're gonna turn down the energy. If it tends to drag, we'll just bump up the energy. Okay, let's go ahead and start. So we have high-speed vacuum, and I like to just have a 2x2 gauze with a little bit of water, because we'll start to develop or build up debris on the tip, and we can just wipe it off with the 2x2 gauze.
You're using laser, you have to have. It's basically cauterizing tissue.
What I do is just start the cut. Nice thing about this is we're not gonna have any bleeding. See, we have minimal char. Yeah, it's cutting very efficient. This is the end cutting laser. My goal with this is to go completely through the fiber until I hit periodontal.
Oh, I love it.
That you can see as I pull up on this lip, we're still getting some fiber laterally. Sometimes this final vertical side will be football shaped if the fibers are going more laterally. Sometimes it's just almost a
Why does it look like Gardner Salad?
very light touch. If I do get get it out of the laser, or I can just cauterize a bleeding point.
He stopped a minute ago, just after flipping it in the middle. That makes sense to your first. Sternotomies are gonna grow back, long term. What he's doing, this is not gonna grow back.
All the way to very often.
Not long. It looks way worse than it is. The nice thing about lasers as well is they act as desensitized. So lasers basically go.
We eliminated fiber detachment and very often. Now we're gonna do is just kind of clean this up, almost like just two.
Even though it looks brutal.
Yeah. Maybe I don't want to live this.
Attachment, you got a little bit of drag here, so it's gonna bump it up.
What do we use lasers for?
What are these lasers for?
Like, what would we as hygienists? Like, am I doing that?
He's just tracing the lines until we can't feel any more of that fibrous tissue.
You should ask.
Going all the way down to where that fibrous.
A little bit more confident, yeah.
Oh, it's like a moving time or something. I think that's like crazy.
A little time right there. Slightly high. Just have to adjust it slightly.
Just cauterize the entire.
Yeah, exactly.
It just looks like that. Like a burn.
We just rolled a paper on it.
About a quarter of a cartwheel of lidocaine.
All
You don't want pretty significant. Within our filing. Alright. So you can see how easy it is with the diode laser and doing a connectomy. You saw that there was no bleeding, how it is finished.
Now, well, that's. Most of the time they don't have to with that. Because the tissue's been cauterized, we're not worried about the wound opening up and bleeding or anything like that. It's a matter of waiting for the epithelium to cover, which epithelium moves quick, within 2 weeks, that's gonna be completely gone. So no sutures, no dressings needed on this. And that's why if I was to get a connectomy, I'm gonna be finding someone that's gonna laser. Okay?
Yeah, why would you not?
Exactly,
No, it's always strong.
exactly. The scalpel is more of like old school technique. Most practicing surgeons and dentists have lasers now and utilize them. So to me, it's kind of a no-brainer. But you might end up working for a dentist that doesn't want to, lasers are expensive, maybe they don't want to invest in it, then your patient might have to just well. So it just depends. But to me, laser all the way. So any questions on your connections? Okay, are we gonna talk to patients about it if we see there's no recession? Okay. All right, let's talk about crown lengthening now, okay? So, crown lengthening is basically our ability to create longer clinical crowns. Okay, clinical meaning the portion of the tooth that's visible, right? We're not changing the CEJ, we're not doing anything like that. All we're doing is just cutting tissue back to expose more of that crown in the oral cavity. Okay. Now with crown lengthening, most of the time, we're definitely removing gingiva, and we usually have to go in and remove a little bone as well. Okay. So this often is going to involve an apically positioned flap and osseous resective surgery, which we talked about last week or two. Okay. Now we're still going to have primary intention because we're able to basically pull or reposition the tissue apically, pull it upwards to expose more of the crown, and we suture it in place. It is going to be sutured in place. We want it to stay apically. Now, we mentioned the different types of healing during the first portion of chapter 29. This guy here is a prime example of healing with reattachment. So we pull this tissue back, but the tissue's not diseased or anything. So once they position it back over the root surfaces, it just reattaches. We don't need to form a long jump on the epithelium. We don't need to form any new fibers. Everything just goes back right where it should be, which is nice. Okay. Now, one thing to note, and I don't want to talk to your patients about, is if they are going to be undergoing clinical crown lengthening or aesthetic crown lengthening, which we'll talk about the difference in shortly, talk to them about hypersensitivity. Okay. Because we have more of the crown exposed, this patient's going to be a little sensitive for a while. It's temporary, but usually for the first week or two, both foods are really going to kind of sing a little bit. It's totally normal, it will go away. But making sure that they know about that ahead of time. So this patient here, if you can believe it or not, this is the same patient. Okay, so this patient had crown lengthening done because she didn't like the appearance of the gummy smile. So what they did was flap back that tissue, flipped away some of the gingiva first, flap back the tissue, possibly recontour the bone if needed, and then reposition it apically so it's at a higher position. Okay. Now we're not really seeing recession here. So basically what happened with this patient case is these are technically still her crowns from an anatomy standpoint. Okay. So EJ is not exposed. But what happened was during her formative stages, the gingiva and bone just kind of position higher up on the tooth. So we're basically going and forcing the bones and bone to kind of go back down. Okay. Now there's two different types of crown lengthening we can run into it. There's functional and there's aesthetic. Now aesthetic is kind of what we just talked about. The patient that has a gummy smile. They don't like the look of their appearance of their smile. So we can go in and perform this surgery. Total side note, kind of side note, but another option for patients like this, and this might come into play if we can finally get certified in Botox in Arizona. If there's certain types of injections of Botox that they can do in the cheek and facial area. So when the patient smiles, they don't pull their lip up as much, and so it kind of rests their lip further down on their smile line as well. So a little less invasive, total size arm, but that's another option for these patients as well. But let's say they just have a really bad gummy smile, Botox isn't gonna do it, we can go in and perform aesthetic crowning. Okay? So strictly going in, doing, improving their smile line, essentially, where there's this excess of now, functional crown lengthening, this is when we really tie into needing to engage osteoplasty and osteotomy procedures as well. So let's say a patient has severe decay on a tooth, and that decay extends subgingially. When we go in place of restoration, we need to chase the decay, right? But what if that decay stops right above the bone? We're worried about biological width, right? You have to maintain enough distance between the restorative margin and the crest of the alveolar bone. So if there's not enough space for a restoration, we can engage in crown lengthening. And basically what they're doing is they're gonna go in, cut away bone, cut away tissue to pull everything down, so that way there's room for the restoration of the place. Okay? Does that make sense? You're gonna run into this a lot, the functional crown lengthening. I personally haven't had any patients go through aesthetic crown lengthening, but I've had more than I can count go through functional. You guys have all seen patients that are paid that broke off the gum line, right? Broken teeth in there, those can be restored, but they have to go through this process. Okay? So here is a breakdown of what aesthetic crown lengthening looks like. Okay, so this is the same patient case we saw earlier. And most of the time with aesthetic crown lengthening, what they'll do is they'll create a little guide for how high they want the gingival margins to be. So that way they can kind of follow it. They don't want to eyeball this, especially when they're dealing with cosmetic dentistry. You don't want to be eyeballing it. Okay. So what they do is they essentially follow their guide and start making scallop incisions and removing the gingiva. Okay. Then they're going to flap the tissue back. And now you can see all of the root exposed, and this is where they can kind of trim down the bone if needed as well. Okay, because if we're removing the gingival margin, we're likely going to need to be removing some of the bone as well, unless the patient has periodontal. Okay. Once everything looks good, they're going to suture it back in place, and already you can see the difference there. The difference in these two photos. Okay. And then over the course of a week or two, things are going to heal up, sutures are going to get removed, and putting the patient back to normal and has a real smile, basically. Okay. Here is another example for you. Okay, so this is the same patient here, and just has some shorter crowns on these teeth. You know, it's not fully symmetrical right here. Tooth number 9, gingival margin is positioned slightly more normal. So this is the post-op. Okay. Now, again, I show you this because yes, we were able to improve the length of the crown, right? It looks a little bit more symmetrical, but unfortunately we developed recession for him. Okay, so again, when the surgeon's going over all of the post-op complications of the patient, they're going to talk about the different risks. And, you know, we're going to do the best we can to give them the perfect smile, but it might result in slight recession as well. That's kind of the only downside of the aesthetic crown. Okay. Questions on those? I have a good video to show you at the very, very end today, kind of comparing gingivectomies to crown lengthening. Okay, kind of get good visuals there. All right, gingivectomies. You guys have heard about gingivectomies by now. Basically, what we're doing is we're going in and removing excess gingival hyperplasia that's present. We can also do gingivectomies on patients if, let's say, tooth number 8 and 9, we're looking at the gingival margin. Tooth number 8 might have a more coronal position gingival margin compared to tooth number 9. Patient doesn't like the look of it. That's fine. Let's just do a little gingivectomy on that bone too to kind of even things out. So it can be something as simple as that, or something as advanced as managing patients with gingival hyperplasia from medications. Okay. One thing to note, though, and I'm sure Ross has talked to us about this as well, is we're not going to perform a gingivectomy on a patient that has medication-induced gingival hyperplasia if they're going to stay on that same medication. Because if we do a gingivectomy, they're on the same med, guess what? Their gums are going to go back. What's the point of that? Okay, so just kind of keep that in the back of your mind. You can absolutely do gingivectomies on patients that are taking anticonvulsants, but The only way we're really gonna be okay with performing this type of procedure is if we're collaborating with our physician and knowing that we change their medication. Which usually isn't gonna happen all that often, especially when we're managing cancer patients, okay? But really good alternative for patients that are worried about aesthetics of their gingival margin too, okay? Now, anytime we're doing a gingivectomy, it's gonna result in a more apical position of the gingival margin, which makes sense, we're cutting away the tissue, so it's gonna be more apical position, okay? Now, gingivoplasty is another term that we can utilize with gingivectomies as well. Kind of similar to osteoplasty and osteotomies, most of the time, these two are gonna go hand in hand. The gingivoplasty is just going in and reshaping and recontouring the tissue, but it's not removing any of the tube supporting tissue. Gingivectomy is gonna remove tube supporting tissue. But most of the time, if we're doing gingivectomies, we're gonna go in and kind of recontour instead of those. They kind of go hand in hand. Okay? Now, gingivectomies were definitely more prominent kind of historically. You're not really gonna run into gingivectomies too often today unless it's strictly for aesthetic purposes, because there's a high rate of surgical relapse, right, which we talked about, especially if we're managing medications. Patients on the same med, it's gonna go back, right? We have really slow wound healing with this. It's also pretty painful because there's nothing we can suture, right? We just cut away the gums. There's nothing to suture in place. So it's secondary intention healing, which can be really uncomfortable for patients. Surgeons usually will place periodontal dressing over this wound to try and alleviate some of the discomfort, but I think they can still end up getting into the bones. Okay. We can get bleeding from this wound as well, just because again, it's a wound. We're really not going in with the intent of preserving keratinized tissue. In fact, most of the time they actually cut away a lot of the keratinized tissue, which is kind of a bummer from a periodontal standpoint, right? And it's also really difficult to maintain aesthetics when we're doing a very wide band of gingivectomy. There are instances, which I'll show you in a video here, where we do localized gingivectomies which can maintain aesthetics. But if we're talking about gingivectomies for gingival hyperplasia, it can be really difficult to mimic the natural contour of the gingival. Okay. All right, so our steps for a gingivectomy, basically what we're doing is we're gonna do a horizontal incision. The difference is an external bevel incision. Okay, external bevel. So what they're doing, let's pretend this is our little scalpel blade right here. They're angling the scalpel to at a 45-degree angle to the tube root, and they're angling it upwards. They're angling it coronally and just kind of shaving off that top portion of the gingiva. Okay. This can also be done with a laser, which I have a video I'll show you as well. So external bevel incision here, not internal bevel, external bevel. Internal bevel is going downward to the apex. External is going upwards towards the crown. Okay. Once they remove the bulk of the tissue, they're going to go through a gingivoplasty, kind of recontouring, reshaping everything. Just like anytime we're doing surgery, they're still going to debride the roots, right? Especially if we have some areas that are exposed there. And like I just said, we're going to definitely cover this with periodontal dressing. This is uncomfortable, it's an exposed wound. We're not going in with the intent of trying to make the tissue to mobilize. We're not worried about that with this. We're covering it just to make it more comfortable for the patients. Okay. Expected healing. So just like I just said, we're going to be dealing with secondary intention. There is no sutures involved with this. No sutures involved. Now, our gingival tissue has the ability to grow kind of, generally speaking, 0.5 millimeters a day. Okay? So what's nice about knowing that, I do want you guys to know that number. What's nice about knowing that is, let's say we did a 5 millimeter wound of our gingivectomy, right? That's going to take, we can basically calculate how many days that's going to take to heal. Okay? That makes sense? Millimeters, we're looking at okay, but knowing the connective tissue exposed, if you really have so it's a little bit of a downside. All right, do we want to take a break before watching the videos?
No.
Okay, raise your hand if you want a break. All right. All right, so let's watch a gingivectomy with the scalpel here. This is just a very, very quick video. So we already went in and made the incisions with where he wanted to remove the tissue, and now he's just going in and kind of pulling that tissue away. See that beautiful scallop line out. But again, this tissue's all completely exposed and open, so that's where our secondary intention comes into play. Look at the difference in the crown right there.
Very satisfying.
Right, yeah, this one's a good.
Yeah, it's a very, very satisfying.
Open pressure there. Just to kind of help stop the bleeding. Like I said, most of the time it's just periodontal dressing, this depends on the degree of severity. Okay, now let's watch a gingivectomy with a diode laser. So this one's more of a conservative approach. The diode lasers, like I said earlier, cauterize the tissue, so you're not gonna see any bleeding. The brown tissue that you're seeing is where that cauterization is happening.
A very common anomaly, especially among females, is that teeth number 8 and 9 are often asymmetrical. And in this case, we see that tooth number 8 is about a millimeter shorter than tooth number 9. So we're going to use the eyelays in the gingivectomy setting in order to correct this situation. We placed a topical anesthetic previously, and because we're only removing about a millimeter of tissue, really not crucial at what angle we hold the laser in order to adjust this tissue. Note that this video is shot in real time, and you can get a sense for how quickly this tissue can be recontoured very, very nicely. Notice how much more efficiently the laser works when you're able to initiate the sides and not use the tip. At this point, you've probably noticed that this is the same patient that we recently completed the labial frenectomy procedure on. I believe that this emphasizes the multifunctional uses of the eyelays, where we're able to do multiple procedures in one appointment, and most of these procedures we were not able to offer previously. Using a wet cotton roll, we're able to remove any excess tissue. And at this point, our procedure is complete. You can see that the length of both 8 and 9 is now identical. I think you'll be amazed at the results we see immediately post-operatively using the diode laser.
Obviously, this would be very expensive, but about how much do you think they're charged for that procedure?
It's a little less. Usually a couple hundred. Most of the time insurance will pick up like 50% of what they're doing, so. Yeah, most of the time a patient's still gonna pay like full amount outside pocket.
So even if they do it purely cosmetic, you think insurance would still?
Excellent question. Is cosmetics? No. Yeah, most of the time insurance companies will not touch anything cosmetic. So even if your patient wants to get for years and they have coverage, insurance is paying for the years for cosmetics. That's an excellent question. We're almost done here, guys. So this is one other video I'm going to show you here. And what this guy does is, he's a dentist and he's going through and basically differentiating between a gingivectomy and crown laser. Okay? Because they have similar ties, but they're different in and of themselves in terms of procedures. And he has some really good pictures and images that he'll show you what the different procedures look like, especially when he talks about the functional crown laser. So we're looking at the
This video is going to be on the difference between crown lengthening and a gingivectomy. Both of those procedures take the gum line and actually raise it up, revealing more of the underlying enamel of the tooth. The difference is that with gingivectomy, you're just going to take away the gum, whereas with crown lengthening, you're going to take away the gum and the bone. So it's a little bit more invasive of a procedure. But let's just go through real quickly how that really plays out. So the crown lengthening procedure, which, by the way, I wish they wouldn't call it that. I wish they called it something else, because we're not really lengthening anything. We're just revealing more of the actual crown or the enamel of the tooth. And so how that would work is if you had an area, let's just say decay or fracture, something had to go below the gum line to fix on a tooth. If it got really close to where the bone is, the bone would have to be reduced down as well as the gum line. So the gum line would be peeled back from the bone would then be reduced, and then the gum tissue would be put back. So you can see in this example, the bone And this area was, the area that was reduced. It started off here at about this level. And then when it got finished, it dropped down. It's down now to this level. The same thing down here, an area of decay below the gum line, remove the bone, and then of course the gums go down along with it. And then we're able to get to that cavity. You can also do it if maybe there's not a cavity, but instead, say the bottom front teeth have worn down quite a bit, and this person needs to do something to stop this further wearing of enamel, but they need to get something like crowns or veneers put on these teeth. But there's nothing you can see, there's nothing really to grab onto or stick onto. The surface area remaining is so minimal that nothing will really work. So you need to get more of that to be exposed. So here they're able to take the gum tissue and the bone and actually lower it, showing more of the enamel. So now you can imagine you can put a veneer or a crown on that tooth and have enough surface area to make that actually stick. Here's another example of a back tooth where the decay is broken off at the gum line, or sorry, the decay or the fracture has led to this tooth being right at the gum line. Now, I'd have to say, and I don't have the x-rays that go with this case, but I would think maybe it might be time to say enough with this tooth. It's already had a root canal, looks like it may have had a post, it's broken off the gum line. The tooth just might need to come out, the dental implant put in. That would probably be the best course of action for this situation. But for whatever reason on this picture, just got this from the internet, it shows the tooth being saved, and now they're going to work with it. And they're able to lower the gum line. And so now you can see you can actually get a crown and get on top, or be able to grip on top of that tooth. There is a downside, however. Look how the gum line comes up nice to this nice little peak and then comes back down. And then after the surgery, the gum line comes up, but then it stops, comes over, and then comes back down. Even if you got a crown put on here, this is going to create kind of this little pocket here and here where food might accumulate, whereas the gum tissue here blocks food from getting stuck in there. So moving the gum tissue down just to reveal more of the tooth, you have to think of, is it really going to be worth it? Because the gum tissue and the resulting contour might lead to more food getting stuck in between the teeth. So we just have to balance it out to see, even though we can do the procedure, if this would really be the best procedure for this case. Let's move on to something a little more subtle. This is going to be just gingivectomy. This is where we're not removing any bone. We're not lifting the gums back away from the gum or from the bone tissue. We're leaving the gums, everything's in place. We're just sculpting away some of the gum tissue. And that can be done with a blade, but these days we do it with lasers. And there's different lasers that are out there. Currently, in our office, we use a CO2 laser, and it does a very nice job of going in and recontouring the gum line. So you can see in this case, it's very subtle, but they're able to take this tooth, or these teeth rather, that are kind of short, a little squatty looking. The teeth themselves aren't short, it's just they have a little too much gum covering them up. And so they can raise them up. I think probably out of all of these, it's the lateral, especially this one, tooth number 10. You can see the definite change from here to here. That looks more like how it should look, okay? Another case showing, here's the case beforehand. The gums are kind of asymmetrical. They went in with a laser, again, not touching the bone at all, and able to just sculpt back in several areas where the gums need to go up. For example, right here, this canine, they didn't touch that one at all, but they did the premolar and looks like some stuff behind it. And then, of course, they did all these other teeth. And then you can see afterwards, after everything's kind of healed up, that gum tissue has healed. It usually takes just about a week or so for the gums to heal, and it's fine. Now, sometimes, however, the gum can grow back. There's going to be an underlying bone underneath here, and if the gum tissue is cut back too much, the gums are going to have a tendency to just kind of grow back to maybe where they were, or probably going to be less. So there might be some rebound whenever we do a gingivectomy procedure. And sometimes they're a little bit more advanced. For example, here you have somebody who has their braces, and the gum tissue is growing down quite a bit over them. Now, this is much more dramatic, but it is not going to be removing any bone. You can tell that these teeth are short because they're just an excess of gum tissue. Now, to be sure, what the dentist probably would have done, they maybe got the patient numb before they did the procedure, and they took a probe and they were able to take the probe and slide it underneath the gums and push it all the way up to the bone to see just really where the bone is. I mean, most of the time, you just look at an x-ray, you can tell where the bone is. But they probably just verified to see if this was just extra flabby gum tissue that needed to be trimmed back. And you can tell now it's much more aesthetic, but it's also going to be much more hygienic as well. They're not going to get bacteria living underneath this gum line that can't be cleaned off with brushing. Now, this patient can get in there and brush these areas. Again, this is immediately post-operatively, and then it's gonna take a couple of weeks for it to heal up. Over here, again, real subtle. Here it is before. They just raised the gum line a little bit right there. And then a week later, you can tell it just kind of healed. And if you look at the before and the after, it's not dramatic, but it does look slightly better, a little bit more symmetrical from where it started. And sometimes that's all it takes is just a little tiny touch to kind of balance out the smile. So you got crown lengthening that involves the bone and the gum. And then you have gingivectomy, which is just the gum tissue. So that's the difference between those two procedures. Thanks. This video is going to be on the difference between crown lengthening and a gingivectomy.
So when we're talking about a gingivectomy, what type of healing are we looking at? Secondary, absolutely. How quickly does the gingival tissue grow over connective tissue? 0.5 millimeters a day. Can you remember that today? What are the consequences of not maintaining a blood supply for a gingival graft? Necrosis, graft failure, okay? Tissue necrosis is bound to happen if we are not ensuring that adequate blood supply. What procedures recommended for patients with a gummy smile? Specifically on the type of crown lengthening. Aesthetic, excellent job. Aesthetic crown lengthening, functional crown lengthening is for decay. Make sure that you differentiate between those two as well, okay? True or false, a laterally displaced flap can be used to treat severe areas of recession. False. Mild to moderate only, okay? A laterally displaced flap does not maintain its own blood supply. False, absolutely, okay, those are false, false. A laterally displaced flap keeps its own blood supply. We're not severing it from the, okay? All right, guys, next week, we're gonna finally finish up
Merry
chapter
Christmas.
29, it's pretty straightforward, okay? And then that lecture is when
And
we'll
then 0.5.
post-op instructions and how to talk to the patient.
Just 0.5.
All right, guys, get out here.
That's not.